Hello, my name is Dr. Bonnie Ky, and I'm the Editor-in-Chief of JACC CardioOncology and the Founders Associate Professor of CardioOncology at the Perelman School of Medicine at the University of Pennsylvania. I am very happy to be joined today by Dr. Deepak Bhatt. He's the Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Health, and he's also a Professor of Medicine at Harvard Medical School. He's well known to all of us in the cardiovascular community. He's the senior author of a state-of-the-art review published in our December 2021 issue of JACC CardioOncology entitled Common Pathophysiology in Cancer, Atrial Fibrillation, Atherosclerosis, and Thrombosis. Deepak, thanks so much for joining me today. I really appreciate you taking the time.
Well, it's great to be with you, and congratulations for all the successes to date of your journal. I think JACC CardioOncology is really serving an important role.
Thank you. Thank you. I wanted to talk to our community with you today about different facets of your article. The first question I had for you is, in your view, what are the most important take-home messages that you want our readers, both the clinicians as well as the scientists, as well as the fellows in training, to understand from your excellent state-of-the-art review?
Well, thanks for that question. I'd say the first thing is probably that readers understand that cancer and atrial fibrillation and atherosclerosis and thrombosis all have a lot in common. They might seem like really different conditions, and it might be that in a hospital, different types of doctors are caring for those different disease states, such as cancer and atherosclerosis, or that researchers are focused on cancer or they're focused on cardiovascular disease, but as your journal is nicely doing, those areas that used to be considered quite different, in fact, have a lot of commonality. That's true when we're caring for patients, but it's also true when we're working in the lab. And here, we had co-authors that were mostly cardiology. The first author, Dr. Levy, is Dr. Leva's cardiology-based, but Dr. Connors, for example, is a hematologist. So we tried to bring in not just the cardiology viewpoint here, but the real points that we tried to make. I think this is obvious to your audience already, but there's a lot of cancer out there. There's a lot of cardiovascular disease out there. So they're just going to coexist by virtue of that fact. But that some issues like thrombosis, we appreciate, are very common in cardiovascular disease. That's the genesis of the majority, say, of acute coronary syndromes, obviously important in states like DVT and PE, but thrombosis is also important in cancer, and likewise bleeding comes up in both those situations as well. And when we're caring for patients, for example, a patient that has an acute coronary syndrome but that also has a malignancy, those patients can be really challenging. Issues of thrombosis and bleeding are an issue in all patients, of course, but in patients with cancer or hematologic malignancies, there can be added issues, things like thrombocytopenia superimposed, prothrombotic states underneath. So there's a lot of clinical situations where things come up, where things like AF and atherosclerosis and cancer are coexisting, but the management of one complicates the management of another.
Certainly, Deepak, I can think of many of my own clinic patients where it is truly a very challenging clinical conundrum in terms of managing the bleeding risk, the thrombosis risk, and particularly in patients with AFib, for example, that have both bleeding risk as well as thrombosis risk, and just how to do that, and really working with patients on an individual level to try to ensure that they can receive the best possible care.
Yeah, and it's tough because if we say we want to practice evidence-based medicines and that randomized clinical trials are the gold standard, I agree with all those statements, but by and large, patients with cancer are excluded from randomized clinical trials, not just in the cardiovascular space, but in other areas as well. So a lot of times when we're making decisions of patients that have cancer, either a history of cancer or in particular active cancer, we're really operating in a data-free zone and operating on our own personal anecdotes or our collective clinical wisdom, which can be quite informative, of course, but still oftentimes in a data-free zone. And that makes clinical decision-making tough. And, added to that, various drugs that are used in cancer obviously can have cardiovascular consequences, as can cancer itself. And the two are sometimes hard to tease apart in observational databases. Obviously, in the laboratory and basic science lab, those sorts of issues can sometimes be teased out more. But, CHIP has gotten a lot of attention lately as something that seems to be associated both with atherosclerosis, but also with cancer, for example. And we've got the immune checkpoint inhibitors, where they've been a major advance in the world of oncology, but occasionally can cause cardiovascular complications, as we all know now. So that's just some examples of the interplay between these different areas.
Yeah, no, exactly. You raise up such excellent points, Deepak. I do hope that our journal can be a vehicle where we can inform those anecdotes with actual scientific evidence, and hopefully, and to better advance the care of our patients. You mentioned CHIP. Tell the community a little bit more about what you think are the key pieces of evidence, and you elaborate on some of these in your state-of-the-art review, but that truly support an important overlap between the pathophysiology of cancer, AFib, athero, and thrombosis.
Yeah, absolutely. And just to be clear, CHIP, I'm talking about clonal hematopoiesis of indeterminate potential. The reason I say that is that acronym is also used in other parts of cardiology, such as in interventional cardiology to refer to complex coronary interventions, CTOs, chronic total occlusions, that sort of thing. But here, of course, we're talking about clonal hematopoiesis. And there is really a lot of emerging literature showing associations between CHIP and things like progression of atherosclerosis, even the development of atrial fibrillation. And right now these are largely associative studies, and the potential, at least in observational analyses, still for residual confounding. Is it just more a marker of aging, or is it specifically a marker of those specific disease states? There's lots of work going on, both on the observational side, but also in basic science labs to tease that out. But it could be that fundamentally, biologically, that cancer and cardiovascular disease have more in common than we realized before. And not just that as people age, they're at higher risk of both. That part is obvious, but in terms of the mechanisms of why, at least in some people, CHIP might be a common denominator. There's a lot of good work going on that area. My good friend, Dr. Peter Libby, for example, has been involved with a lot of research along with other collaborators in this area and really all over the world. So I think we're going to hear a lot more about CHIP. And, there are even some places that are starting CHIP clinics. Once you look, you find, but then when you find, what do you do with these patients? So I think as especially centers that have an interest in cardio-onc amass larger numbers of these patients and follow them longitudinally and also do fancy biological tests on them, we'll have greater insight into exactly what to do with patients that have CHIP and what does it really mean and what might be actionable in terms of reducing future risk.
Exactly. Great points. And along those lines, what do you think, where does the field need to go in order to better advance our understanding of this overlap? Larger clinical trials, more focused on cancer patients specifically, more mechanistic studies? Where do you think we need to go as a field?
I guess I'd say yes to all of the above. I think all those things need to happen. And they are happening. And, cardio-oncology centers in particular have really added a lot of fuel in a good way to this scientific fire. I do think, though, there's some things we really need to do. I'll tell you, Dana-Farber Cancer Center, which is right next door to Brigham Women's Hospital, we serve as their cardiology department. It's pretty amazing the percentage of patients that they enroll in randomized clinical trials. It far outstrips what we do in cardiovascular medicine by an order of magnitude, really, in terms of patients that get enrolled in trials. Now, some of that has to do with if you want, as a patient, access to certain therapies, the only way to get them is through a trial. So part of it is that. But nonetheless, there's a culture there of enrolling a large number of patients in randomized clinical trials. And I think if we could sort of do that very broadly in cardiovascular medicine, even just aside from cancer, that would be good. But in particular, in patients with a history of cancer, with active cancer, I think, it's unfortunate they get excluded from randomized clinical trials de facto most of the time. Maybe skin cancers will get in, but usually if patients have a significant cancer history, certainly anytime in the near future, they're excluded. And then it really hampers our decision-making in such patients. It's sort of like, I guess I'll use the word bias, where, in the past, There were patients who were women that were getting excluded from cardiovascular trials. That's still an issue to an extent. Older patients, especially you'd say late 80s, 90s, that get excluded from trials. I wouldn't say that problem's totally solved either. But another group where they just tend to get excluded from trials are patients where the word cancer is anywhere in their medical chart, and that really hurts us. So I think in the future it'd be good to try to enroll these sorts of patients and sort of not exclude them just because of outdated information that the person screening might have. That is, a lot of us, I think, have this impression of cancer that might be based on what we learned in medical schools 10 or 20 or 30 years ago, depending on the person. But there's been such rapid changes in the field of cancer, such advances in terms of medical therapy, in some cases even radiation and surgical therapy, patients doing much better. So I think it's important to have better representation of patients with cancer in a randomized trial. So that's one step, I think, that would be relatively easy to do. Maybe it's not that easy to do, but at least conceptually relatively easy to do, that could, in a few years, reap lots of dividends.
Excellent point. Exactly. And cancer, you're absolutely right. The landscape of cancer treatment is constantly evolving and making dramatic improvements and advances. And I always say we need to keep pace with our oncologists and all the excellent work that they're doing. Well, Deepak, thanks so much for joining me today. I really appreciate all that you do for the field of cardiovascular medicine and all of your important contributions to JACC and JACC Cardio-Oncology. And I will encourage all of you in our community to read this important piece. Thank you.
Yes, thanks so much for having me. And thanks for publishing this review article. I hope it helps the readers. I hope they find it interesting.
Thanks.